discussing amongst yourself. Thank you for your cooperation. We are pleased to invite your attention to the next segment of our program. It's a pleasure to present the Professor B.B. Joshi Oration, delving into the complexity of hand surgery. We are honored to invite Dr. Rajendra Nehete to come over the dais. Now, I request Dr. Rajendra Nehete to invite the orator here on the stage.
Anil, will you please escort Dr. Greg Ben? This is the second prestigious oration of our association, and Dr. B.B. Joshi was one of the pioneer hand surgeons from Mumbai. Originally from the area of Pakistan, and he did medical schooling in Pakistan. After that, he joined Grand Medical College, Mumbai. And he worked in Mumbai in a ESIS hospital, a government hospital, where there were a lot of workers used to come with hand injuries, and he devoted his time to develop hand surgical field in Mumbai area. He was a tough taskmaster, and his students sitting out here might remember him that he didn't spare anyone when it comes to patient care. I was fascinated when as a plastic surgery student, I met him, and I went to his clinic and I saw his workshop. He had immense interest in developing different types of splints for the patients, and he used to personally take care that every patient is being given an excellent splintage and excellent physiotherapy. He had very innovative mind, and all of us will remember his many flaps, which innovatively he always has a keen interest in improving sensation at the fingertips, and he tried so many flaps and innovated few flaps in his name. I welcome Dr. Anil Bhatt to introduce today's orator, Dr. Greg Ben, for this oration.
So good morning again. Professor Greg Ben, who is currently the professor and head of upper limb surgery at Flinders University of South Australia, Adelaide. We all saw in the morning the research interests, basically anatomy, biomechanics, imaging, arthroscopy, reconstructive surgery of the wrist and elbow, and instabilities. And more than 200 peer-reviewed journal articles and 100 book chapters, and especially the books Kienbock's disease with David Lichtman, and arthroscopy and endoscopy of the elbow, wrist, and hand. Numerous awards, including Terry Whipple Prize in 2008 by the IVAS, and Australian Orthopaedic Association Research Award 2009. And he also supports design and applications of advanced surgical training models for education. He's the AHSS President-elect, IFSSH Executive Board Member at Large, the IVAS President in 21-22, the APWA President in 2017 and 19, and the Shoulder and Elbow Society of Australia President 2004 and 6. We are privileged to have him for this oration. Thank you so much, sir.
Thank you very much. It's a wonderful privilege to be able to provide the Joshi Oration. Joshi was clearly a legend of orthopedic surgery and hand surgery in India. If you go back to 1950, when he first started in was Bombay then. He was the first orthopaedic surgeon in India. He was self-taught, and then he taught the entire nation hand surgery. Clearly, it was a major contribution. If we have a look at his library in the background here, he was so passionate about the excellence of knowledge that he basically bought every textbook and journal that became available, and he kept them available for himself and for his staff, and if there was any issues or academic points, he would then refer to them. Apparently, he literally knew the words in almost every one of these textbooks, but he actually bought these textbooks at his own cost. It's already been discussed how he's been very actively involved with sensory flaps, and he described that if a man was blind and he also had complex injuries to his fingers, then he was blind twice. And I think the trainees were able to see and learn and understand these principles and apply it in their patients. He was an internationally respected surgeon. He is a pioneer of the IFSSH, and Guy Pulvertuft was one of his visitors and came in and was very impressed with a lot of his work, particularly the sensate flaps concept. During his career, he was very passionate about all the splints and using those, and apparently there were, in his own hospital, some of the patients and some of the staff would make various splints, even out of aluminium splints and chicken wire. But it was the progression to the Joshi external stabilisation system that he developed, which was a very cheap system of being able to provide external fixation for pretty well all patients and all surgeons throughout India and throughout the world. He revolutionised and developed this entire concept, and I think changed the management of these patients, particularly in the Indian environment. And it was able to be cheap. He didn't patent it so that other people were able to use it. It's already been discussed about the importance of him as a teacher and as a mentor. He often described the concept of, I am but a gardener, and he would be preparing the garden, applying the seeds and watching it grow and learn from that. He would also ask about what did you learn today to try and to get the trainees to understand what was going on. And we've already talked about the importance of the splints and the post-operative management. It wasn't just the surgery, it involved the whole spectrum of management. I'm now going to go on to Kienbock. So Robert Kienbock was a radiologist from Austria. He graduated the same year that Röntgen discovered X-rays, and he then did extra training in London with a physicist, learning about the clinical application of radiographs. He then became a postdoctorate lecturer in radiology, the head of one of the big radiology institutes when it was built, and he created the concept of looking at a dosimeter, which was probably quite important because Röntgen's wife actually died from radiation poisoning, as she was one of the first patients to receive the radiation. In 1910, he published this paper, which we think is very famous, where it outlines the role of avascular necrosis of the lunate in an atraumatic model. But Kienbock achieved a lot of other things as well. He was the first president of the Austrian Radiology Society. He was made the extraordinary professor of radiology. He published an 8-volume textbook, 250 papers, and he was basically the founder of the speciality of radiology. In 1933, when the Nazis invaded Austria, because of his Jewish heritage, he lost all of his privileges, he lost his position, and things were obviously very complex and difficult. He was able to continue to work, but other members of his family and his fraternity were actually not ever seen again as they were sent to various camps. So what's Kienbock's legacy? For us, it's Kienbock's disease. But really, his real legacy is in radiology, where he's a pioneer of the profession. He's the founder of radiology. He is the Joshi of radiology, as it way back at that point in time. And the Austrian Radiology Society award in his honour is for outstanding research and innovation. David Lichtman put together this series of photographs and linked them to Lichtman's grading from grade 2 to grade 4. But I put together these other ones. This is the Joshi grade 2 to grade 4 as he progresses through his period of time. So we can see the young, inspiring surgeon and leading to the very senior surgeon who has then become the advisor for many groups. In 1975, David Lippman published this classification, which has become something that we all use. It goes from grade 1, where you might only identify it on MRI, grade 2, sclerosis, collapse, and then it starts to involve the wrist with grade 3B, the scaphoids going into flexion, showing that there's a collapse of the radial column and leading to grade 4, which is a KDAC, or Kienbock's disease advanced collapse. In 2006, I published a concept of arthroscopy to be able to assess the articular surfaces and to find it if there was a functional articulation, which is that it's smooth and glistening and a probe would be in a normal way. Every patient that we saw with Kienbock's had synovitis, so we did not use that as a grading system. For the non-functional articulations, such as this lunate facet, we can see it's sclerotic. There's a carving into it from some of the lunate deformities, and we would describe this as a non-functional articulation. And we tried to use this to help understand which surgical procedure we should perform. So a functioning articulation is smooth and glistening, and non-functioning could be degenerate, a false floor, a fracture, and we've already talked about synovitis. So this really defined, actually for the first time, that articular surfaces were important in the management of Kienbock's disease. And so when we look at the central column of the carpus, we've got the lunate and the capitate there, we looked at whether the articulations were functional. So on your left, all 4 articulations are intact. On the right, all 4 are degenerate or non-functional. And grade 2 can be in the radiocarpal joint, or there could be an associated lunate fracture. And we set up a concept that basically the principle would be we'd remove, fuse or bypass the abnormal articulations and try and leave the wrist together, mobilising with the functional articulations. In 2010, I was invited to the IFSH by David Lippman with a very esteemed group of surgeons. I was the young boy on the side. I think I'd just started shaving. But we've got Ulrich Lantz, who described bone morphogenetic protein, Professor Nakamura, Peter Amadio, Mark Garcia-Elias, the biggest hitters in the world on wrist surgery at the time, and they spoke on all the common topics. To my great surprise, they all said they didn't know what to do, and all of them basically picked one operation. They either liked vascularised bone grafts or radial shortening or whatever they liked. They basically did it for every case. And to me, that just didn't seem right. I thought it was important to define the pathology, define the articulations, and direct the appropriate treatment for that. So the concept that I had was to assess the articular cartilage, and I thought, why is this different to degenerative osteoarthritis of the wrist? Obviously there's some differences, but the way the articulations work, I thought it was important. At that session, after my presentation, I actually got pretty well all the questions, despite the fact we had this esteemed faculty. And Mark Garcia-Elias, as he always does, summarised things and came up with a perfect part of the answer at the end. And he described a 55-year-old lady that he had seen 25 years ago. And the patient said to him, "I'm sure you've got my records. I saw this young surgeon." So Mark got through his medical records and he found that he'd seen the patient 25 years ago and the patient had Kienbock's, and he decided not to treat them with surgery because the pain wasn't too bad. 25 years later, they were presenting with some other problem. The message really was that they don't all need surgery, and many of the patients will actually stabilise and do okay. And I think that would be the experience of some people in this room. Having finished that session, which was very important for me in my progress, I realised that many people in the room did not do arthroscopy, and it was really not appropriate to just use arthroscopy as a grading tool, that we should in fact think about it as an articular-based approach, not just arthroscopy. So for example, the MRI that you see there, you can see the articulations look pretty good. So in fact, maybe that would be in our grade 0, sorry. Or the one on the right, clearly the lunate and lunate facet are degenerate, and that patient clearly has a problem. You don't need arthroscopy for that. But the important point was that you had to assess the articular components of the joint to be able to define the best form of treatment if you needed to do surgery. In 2013, we published this paper on micro-CT analysis of the normal lunate and lunate fractures. So I collected lunates that we removed as part of a proximal row carpectomy, and we looked at the characteristics of the fractures, and we looked at the associated avascular necrosis, and we're able to define, importantly, how the lunate works. So you can see the proximal subchondral bone plate, distal plate, and there's a series of trabeculae spanning between them. We realised that some of these fractures, a nutcracker type fracture as seen here, and you can see in the middle image on the right how the capitate is central, and you can see the fractures propagated away from the capitate and causing a coronal and in fact a sagittal fracture. When we looked at this example here, in the background you can see a normal lunate, and in the foreground you can see a lunate we removed from a proximal row carpectomy, and we put it all together. We can see this massive area in the middle of all the bone that's reabsorbed. So where the cortical bone tends to be more resilient, the endosteal bone is very soft and friable and will break, and we can see on the bottom left the joint irregularity that we would identify if we were to look in with an arthroscopy. After being involved with that IFSH session, David Lippman asked me to join him to put together a publication on Kienbock's disease. At first I actually felt this was quite a daunting task, and but I took it on after some discussion with senior members of the Australian Hand Society, which I'm very grateful to them for. But anyway, the concept was looking at the basic science, and in this I put together a concept of the basic science model of avascular necrosis. We looked at all the classifications, treatment options, and we developed what was ultimately called the Lippman-Bain algorithm. So Dr. Irasi published this photograph in the book, which included a complex fragmentation of the lunate. We can see only part of the lunate is vascularized on its volar aspect. The articular cartilage looks normal. It's pretty good. So in fact, despite these fracture fragments, we can see the articular cartilage looks pretty good. Having gone through all this, I established this concept of the etiology of Kienbock's, and I thought it was more related to stress fractures, the microstructure of the lunate, the venous drainage of the lunate, and the concept of compartment syndrome of the bone, and a lot less about the arterial blood supply of the bone. I thought that was less important than all those other factors. And this fundamental principle is the basic science model of Kienbock's disease. You will know from the literature there are a number of factors that are thought to be associated with a low risk of Kienbock's disease. However, if you've got a type 1 lunate, which is like 90%, a trapezoidal lunate, it's smaller, a single vessel, or it's uncovered, which means that more of the lunate is sitting out on the ulnar side of the radius. Those patients are more likely to have Kienbock's, negative ulnar variance, and a flatter radial inclination. The Japanese authors have described there are some cases where there's increased radial inclination. And we look at the 4D CT scan of this case here. I was quite amazed. I can see the exact template stress fracture of the radius on the volar aspect of the lunate. The lunate is punching into the radius, and it's created impaction stress fracture on the volar aspect of the lunate. And if we look at this example here, this is the same case, I think. We can see the subchondral fracture. The one on the bottom right is similar to the crest fracture that we know in the hip, but it's exactly the same shape as the lunate. It's as the radius that's smacked in by the radius. And if we overlay this micro CT and we look at the forces that are placed onto the lunate, and we can see where the characteristic fractures occur in this particular patient. It's interesting to me that you might be able to see it from the back, but on the volar aspect, proximal aspect of the lunate specimen, we can actually see that there's a little fracture in that cadaveric dry bone lunate. If we go through the forces that are applied onto the lunate, when the wrist goes into radial deviation, and particularly making a clenched fist, the volar ligaments become taut and force and pull the lunate right down, and if the lunate is sitting over the top and lateral, or to the ulnar side of the radius, that cantilever effect causes the subchondral fracture. And if you look at this arthrogram, you can see that the forces through the radius here will be normal, and then there's a cliff as to where the fracture is likely to occur because the forces are not transmitted across the TFC. So mechanical aspects are important in the development of Kienbock's disease. And if we look at the various types of fractures that we've identified, we can see that there's a multitude of types, whether they be axial, transverse, shearing fractures, or even complex type of fractures. And then there can be reabsorption. And this example here, where we've taken the lunate out, we can see there's almost no bone between the proximal and distal aspects of the lunate, but we can see, interestingly, we've got this new bone formation, this healing. It's a physiological, normal response to the trauma and the stresses that the wrist has gone through to try and regenerate the lunate. So the CT scans, we demonstrate this fragmentation. The CT scan is the best way to define the details of the fractures and of its collapse. We've been using these 4D CT scans, and we can see the movement that occurs between the proximal and distal subchondral bone plates. So once it starts to fragment, if it hasn't healed, then it can basically grind away. And if we look at this lunate with a CT scan, we can see on the proximal aspect, we've got this honeycombing of the lunate. We can see that that bone is not going to be strong enough to withstand any significant forces, and that's going to lead to that further fragmentation. We can see the fractures and reabsorption, and there's no subchondral bone plate left in that aspect. The other thing that's very interesting, and I think this is where we're going to start to get a better understanding. So if we look here, the lunate is abnormally wide. We've got ulnar translocation of the carpus. This is Kienbock's disease instability. So it's an instability caused by a fragmentation of the lunate, allowing it to be wider, and a collapse. If we overlay the carpus, the anatomy, we can see that the short radiolunate ligament will be still attached to that fragment, and the lunotriquetral and scapholunate ligaments will still be attached. So it's fundamentally a type of carpal instability as well. Many of you would have learned in your training about the arterial supply of the lunate, and this is well described in the literature. Lee first described a single volar vessel in about 14% of cases, and that there would be no anastomosis between the volar and dorsal aspect in 7%. Gilberman described that these type of configurations had an increased risk of developing Kienbock's disease. Rainer Schmidt did some fantastic work on the gadolinium IV enhanced MRI scans. So the image on the left is a standard MRI, and he's given intravenous gadolinium into the lunate, and you can see it all lights up. So it demonstrates that it's perfusion. So perfusion and avascular necrosis are different things though. So avascular necrosis is death, perfusion just means blood supply. He created a classification, which you can see on the bottom, which you'll need to look up in more detail to go through it. But I think it has a place, particularly if you are a surgeon that likes to do vascularized bone grafts. So the arterial supply of the lunate is important. Harry Crock, who's one of the most amazing orthopaedic surgeons from Melbourne, he's unfortunately passed away, wrote this incredible book in 1996 on the vascularity of the bone. In that book, he describes a subchondral venous plexus in the knee of the medial and femoral condyles and in the patella. That book was published in 1967. And he wrote in the book that he wasn't sure of its significance in osteoarthritis or avascular necrosis. This is a patella. We can see X-ray, venous and arterial assessment of the patella. And these are his micrographs that show the articular cartilage and the subchondral bone plate there. And this is a venous, like a big vein. And you can even see the water-air line, and you can see in this example, the vein lying directly adjacent to the subchondral bone plate. I thought this was incredible. I took our micro CT and stylized with a bit of PowerPoint art to show where these veins would lie. And we can see here, using his images, that we would create a venous gutter in the subchondral bone plate that spans across in a linear fashion across the articular surfaces in the knee, but also in other joints, and I expect including the lunate. If you get a fracture of the subchondral bone plate, it is strategically placed to lead to an obstruction of the venous drainage at a localized level. This image is from his book. This is a venogram of the lunate. Incredible, isn't it? You can see here the venous plexus all through the, it's not an arterial one, it's a venous one. And using a bit of PowerPoint art, we can see where these main veins might be. And if I create his subarticular plexus parallel to the articular surface, and we create a stress fracture, will lead to a localized area of venous hypertension, and subsequently that leads to necrosis. Having looked at this, I thought to myself, wait a minute, what's a type 1 lunate? Because sometimes you see the entire lunate whited out. And I thought, how does that occur? Because my concept at the bottom would not cause the entire lunate to cause troubles. In his book, he describes wherever an artery goes into a bone, there is always a vein. And I thought, wait a minute, what about if we obstruct the venous drainage of the outflow vein on the volar or dorsal aspect of the artery, and a patient has a solitary artery, then that must be a factor. 1 month later into my clinic came this patient with their scans, and I thought, oh my God, this is exactly what I was looking at. And when I looked at this CT, we can see there's this big island, I think it's like a venous island, I'm not totally sure because we haven't done histology on it, but also there's one in the triquetrum, and also the ulnar stylet I thought looked a bit unusual. I don't know if that's an artifact or whether that's the truth. But what I do know is on the MRI that all this tissue is edematous. I postulate, I can't prove, that the cause of this is due to some localized trauma or pathology or variation in the anatomy that causes a localized obstruction of the venous drainage, leading to a secondary venous hypertension of the entire lunate, which fits with our model. If you've got the whole bone involved, or even just a localized area, the concept of compartment syndrome of the bone has been well described in the hip. And if we look here, the arterial inflow is of the order of 60 millimeters of mercury. And we know if you have a lunate fracture, it's unlikely to lead to Kienbock's disease. The venous drainage on the other side is more like 5 or 10 millimeters of mercury. In this room, there are many microsurgeons, and they'll know if you do a free flap or you revascularize a finger, if you just put a little bit of pressure on the venous drainage, that venous drainage will obstruct and the patient will lose the flap or lose the finger. So the venous drainage is one of those things that's very critical. Jensen did a very interesting study where he placed a needle into the lunate and measured the intraosseous pressure in the lunate. And what he found in a normal lunate, it may be 10 or 20 millimeters of mercury, but in Kienbock's disease, it may go as high as 150 millimeters of mercury. So there's clearly something going on, and if you've got 150 millimeters of mercury inside the lunate, then, and the venous drainage is 5, then it obstructs it. There's got to be a significant problem there. So if you look on the right, so what happens, the venous hypertension occurs, it causes some local ischemia. The fat cells are very sensitive to hypoxia, and if they then swell, that's a normal response, and that leads to obstruction further of the venous drainage and secondary osteonecrosis. The studies in the hip have demonstrated that a single episode of ischemia will not cause avascular necrosis. It needs multiple episodes of assault on the vascularity to lead to avas necrosis. So I think this is a recurring theme that occurs, leads to localized venous obstruction, causing compartment syndrome locally, and then that affects the avas necrosis. So going on now, this is a specimen removed from a patient who had proximal row carpectomy, and we can see that there's obvious fractures through here. We can see the fibrous tissue, and we can also see this whole subchondral bone plate is basically gone. It's all been reabsorbed, and there's a false floor. So if we had a scope and put a probe on it and pushing onto it, it would then elevate that subchondral bone plate. And what's interesting, like that other example, this is all new bone formation. This bone is trying to regenerate. It's trying to do what bone does best, and that's trying to heal. Down the bottom here, it can't heal because of the localized fibrosis and scarring and contractures in the localized vessels. So this is true avas necrosis. The articular cartilage on the proximal aspect looks almost pristine. So articular cartilage involvement in Kienbock's disease can often be late. And if we look more distally, it's degenerate. But we know articular cartilage can't heal, so it occurs late, but if it does occur, it's a very bad thing in Kienbock's disease. So we need to be aware of those aspects. The natural history is something that's often discussed and is very important in any community, and particularly probably here as well, where you've got massive numbers of patients. But David Littman wrote in this chapter in the book about that there's a natural radiological progression. The patients tend to get a bit stiffer. They end up with about 65% of the normal grip strength, and those factors are related to the radioscaphoid angle, so as it's leading to collapse. The severity of symptoms does not correlate with the radiographs at all times, and the prognosis is worse for collapse if they have ulnar negative variants, older, or they're smokers. So it's common for patients with Kienbock's disease at a long-term follow-up to have pain in the wrist, but it's probably not debilitating for most of the patients, and for these reasons, many patients with Kienbock's disease will not require surgery. We performed a systematic review where we looked at a series of patients from the literature who had had 2 episodes where we got full details of the patient's outcomes and their radiographs. It's interesting to look at the distribution of the ages. And so if you look at the adult group, which is the most common, it's more common in men, it's more common in the dominant wrist, and it usually has a negative ulnar variance. Teen box, which is those between the ages of, say, 12 and 19, they represent about 20%, and it's more common in men, or boys, I suppose, and there is a potential to remodel. The infantile, less than 15, they have a much better chance of remodeling, and these are quite rare. The other interesting group is the older patients, who are older than 60. They represent 23% of this group. They're much more common to be females. They have a positive ulnar variance, not negative, they're positive ulnar variance. They have associated degenerative changes. They typically have less pain, and they may have osteoporosis. These patients usually do not require surgery either, despite the fact that x-rays don't look very good. So the way I like to think about this is that there's 3 different types of phenotypes: the old one, the adults, and the younger ones, and they're fundamentally different, and they need to be treated differently as well. We also looked at the staging of these patients, and basically the 4 boxes, stage 1 through to stage 4, demonstrates the longer-term radiological outcome. And I doubt you can see it from the back, but basically on the left it goes from 0 years to 25 years. So when any study had the outcome, we were able to then graph where they progressed to. The interesting thing is, the only cases that regressed, went backwards, are those that are grade 3. All the others progressed. So radiologically, almost all of them progress, or they stay the same. So in fact, about 50% stay the same, and 5% regress, and 45% are progressing. So the next thing, particularly in the book, was the future of Kienbock's disease, and we created a new algorithm. So David and I actually spent 2 years on this, and what we thought about was, what do you see? When you do your x-rays, This is what you see on your x-rays, your arthroscopy, or your MRI scan. And you might consider doing a classification using Lichtman, Bain, or the Schmidt classifications. But what we would interpret was the osseous changes, the bone changes, so osseous, vascular and cartilage changes of the different classifications, and we created a new concept of Kienbock's disease which includes all three of these factors. And what's important is it includes these factors, but it includes the lunate plus in fact the entire wrist. It's not just a disease of the lunate, it's primarily a disease of the lunate and secondarily a disease of the wrist. So the algorithm that we had was, we had to make it as simple as we could, which is A, B, C, the age, the bone, which is the lunate, and then the carpus. We've already discussed that the younger patients, less than 20 or older than 70, will do better and can be managed initially without surgery. The B, which is the bone of the lunate, we look to see if it's intact or whether it's compromised, and those that are intact, we try and preserve it and protect it with an unloading procedure, and those where it's compromised, we need to look at using we're starting to do what we call a multimodal approach. And once the wrist becomes involved, we're then starting to use motion preserving procedures similar to what we might do with degenerative osteoarthritis. So for the Kienbock's, good prognosis, but those that fail may be epiphysodesis and interestingly an STT joint pinning to allow the lunate to revascularize. When we go on to the state of the lunate, whether it's intact, such as a grade B1, or compromised, or whether it's we need to look at a salvage option. So if we need to protect it, we like to consider doing either a radial shortening procedure or a capitate shortening procedure so that we're not actually violating the lunate. And the technique we now use is a single cut osteotomy. So this is a simpler technique than what was done in the past, and it's a less morbid procedure. So we're doing an osteotomy parallel to the articular surface, adjacent, about just proximal to the brachioradialis and the distal radioulnar joint. So we use either an oscillating saw or one of these new routers that are used like for the foot surgeons, a high-speed router to take out that thin slice of bone. It's just one pass of the oscillating saw or the side-cutting reamer, so that it just narrows it down. We just want to change the mechanics a bit. We don't need to change it a lot. The capitate shortening osteotomy is similar. We take out a little bit of the back of the third metacarpal. We put a wire, cannulated drill, same oscillating saw. You can see the vascularity at that level, similar to the STT joint, will preserve the vascularity, and then we just put a screw in it. We deliberately put the wire and the drill first before we use the oscillating saw, so that we can then just put the wire in so it's all stable when we do it, we don't lose position. The elephant in the room in Kienbock's disease for the last 20 years has been the concept of radial farage or core decompression. This is basically making a hole in the cortex, scraping it around a bit, and trying to create what the South Americans describe as a vascular storm, and it's reported to improve the pain. From the work that I've done, I think that this is related to the concept of increasing the arterial pressure, which indirectly leads to a greater flow through and it improves the venous drainage, a little bit like the concepts of cardiac failure. This is an indirect form of revascularization of the wrist and the carpus. So if we look at the lunate that's compromised, this becomes more complicated and there's different ways to do it. But basically we can see here we've got this lunate that's floating, the subchondral bone plate. The articular surface doesn't look too bad, but clearly there's a problem with a subchondral fracture. The easiest of the bone graft techniques is a Horry technique, but there's also many other techniques, and I know many surgeons in this group are experts in microvascular work. The other concept is whether to put a screw across it. I'm concerned that this will won't be a satisfactory outcome in this group. If you are going to do it, I think you should consider using a gadolinium-enhanced MRI to better understand the vascularity. The other concept is the medial femoral trochlear graft, which takes the articular surface from the medial femoral condyle, puts it into the wrist. I'm a bit concerned about the complexity of this sort of procedure. It's not something I do myself, but I'd like to acknowledge also Jim Higgins, who published this paper just recently, and he's taken this sort of complex case, he's opened it up, he's put the bone graft in, but he's also put sutures from the volar to the dorsal aspect to stabilise it. So this is one of the images from his paper, and you can see how that lunate is actually healed. It's not a great shape of the lunate, but it's actually healed. So I think there is further work to be done in this area. But having looked at all of these concepts of the revascularisation, particularly the free grafts, I couldn't help but think that maybe we were being too aggressive, particularly in a scenario where we know that radial shortening is actually not too bad, radial farage is not too bad, and the natural history may be that they don't have that much pain. So I looked at the philosophy of this, and I wondered whether we could go for a lower morbidity concept and of what I call a multimodal approach. And that is to use the concepts of unloading, as I've shown you, maybe do a vascularised graft, but make it simple, and use K-wires to protect it. The concept of multimodal treatment is not new. Rheumatoid arthritis, tuberculosis and cancer all have triple therapies for their management. And by affecting different aspects, then hopefully we can correct that. So this is a case I did recently where I've used the farage of the radius to give increased vascularisation. I'm unloading the lunate, which you can see here the lunate looks pretty good. And I've put bone graft in arthroscopically assisted into the lunate using this multimodal approach. But it's not like I've got big cuts and big complex things, but the wire still needs to stay in. I think further work's required in this area. The other area that's being advanced more recently is an arthroscopic excision of the lunate. I'm not sure about that at this point in time because of the concern of ulnar translocation. And then finally, when we go on to the concept of the patient who has the carpal compromise, such as we can see here, the proximal row carpectomy and the scaphocapitate fusion. The scaphocapitate fusion is the preferred option as the way it loads, I think, is better. And it's important to have the scaphoid be tall so that we're able to unload the central column. There are cases where we would just pin the scaphoid to the capitate, particularly in the younger patient, and the concept of whether we excise the lunate is important, but we would tend to not excise the lunate if we can. At this point in time, it's my opinion that there are no arthroplasty options that are currently acceptable for the management of Kienbock's disease. However, I expect with advances in carpal kinematics that will change. In summary, I believe that the etiology of Kienbock's disease is more importantly related to the microstructure, the stresses across the subchondral bone plate, the venous drainage and the compartment syndrome of bone in a patient with an at-risk wrist. I think that this basic science model of avascular necrosis is important and it applies to other areas. We also believe that the way that the loading of the lunate works between the capitate and the radius leads to forces that create tension across the lunate ligament attachments and also lead to the subchondral fracture, the coronal fractures, the sagittal fractures and avulsion of the ligaments. Arthroscopy has a place in the assessment, the classification and treatment of Kienbock's disease. The grade A are managed usually without surgery. The grade B, if they're painful and have a problem, we should unload it or consider multimodal approach. And finally, we need to look at motion preserving procedures for patients with advanced changes. I'd like to thank the Indian Hand Society for the great pleasure to be able to provide the Joshi Oration this year. Thank you very much.
Thank you, sir, for accepting our invitation and delivering this oration. And we must appreciate the monumental work you have done on this small bone in the hand. Your insights into the anatomy, physiology of this bone and the multimodal approach. We will always cherish the memories of this oration delivered by you at Indian Society. Thank you very much.